Tropical medicine tuberculosis. Tuberculosis. Introduction. Tuberculosis, or TB short for tubercle bacillus, is a common and, in many cases, fatal infectious disease caused by various strains of mycobacteria. Tuberculosis typically attacks the lungs, but can also affect other parts of the body. It affects 1/3 of the world's population, 1/3 or 3/10. In HIV/AIDS, the probability of getting tuberculosis is high. Etiology. It is caused by Mycobacterium tuberculosis, a small, aerobic, non-motile bacillus. Mode of spread. It is spread through the air when people who have an active TB infection cough, sneeze, or otherwise transmit respiratory fluids through the air. Through blood, hematogenous spread. Types. O. Pulmonary tuberculosis. O. Extrapulmonary tuberculosis. Risk factors. A number of factors make people more susceptible to TB infections. The most important risk factor globally is HIV. 13% of all people with TB are infected by the virus. Tuberculosis is closely linked to both overcrowding and malnutrition, making it one of the principal diseases of poverty. Inhabitants and employees of areas where vulnerable people gather, e.g. prisons and homeless shelters. Medically underprivileged and resource-poor communities, high-risk ethnic minorities. Children in close contact with high-risk category patients. Healthcare providers serving TB patients. Chronic lung disease is another significant risk factor. Those who smoke cigarettes have nearly twice the risk of TB than non-smokers. Other disease states can also increase the risk of developing tuberculosis. These include alcoholism and diabetes mellitus. Epidemiology. Black small square. 1/3 of the world population is infected with tuberculosis. Black small square. It causes 25% of adult preventable deaths, and 3/4 of these people are in productive age. Tropical medicine tuberculosis. Primary tuberculosis. It occurs in persons who have never had previous exposure to tubercle bacilli. Tubercle bacilli are inhaled, reach the lungs, and lodge in the alveoli where they multiply. They then spread to hilar lymph nodes, from where they can spread to the whole body via lymphatic system and blood. 6 weeks after primary infection, the body develops an immune response to the tubercle bacilli, and this stops the multiplication of the tubercle bacilli. Some bacilli die, and the remaining walled off by epithelioid cells, immune cells, forming a gonfocus. This can stay for years in primary tuberculosis. The gonfocus and hilar lymphadenopathy form a primary complex in primary tuberculosis. 10% of the people who get primary infection develop tuberculosis disease. Secondary tuberculosis. It is due to reactivation of tubercle bacilli acquired in primary infections. Reinfection by tubercle bacilli in a person who is already exposed to the organisms. Pathogenesis. TB infection begins when the mycobacteria reach the pulmonary alveoli, where they invade and replicate. Tuberculosis of the lungs may also occur via infection from the bloodstream. This hematogenous transmission can also spread infection to more distant sites, such as peripheral lymph nodes, the kidneys, the brain, and the bones. Infection with Mycobacterium tuberculosis causes an inflammatory response leading to granuloma formation, collection of activated macrophages, T lymphocytes, B lymphocytes, and fibroblasts are among the cells that aggregate to form granulomas, with lymphocytes surrounding the infected macrophages. Other lymphocytes form a peripheral rim around the tubercle bacilli, forming a gonfocus. Bacteria inside the granuloma can become dormant, resulting in latent infection. Another feature of the granulomas is the development of abnormal cell death, necrosis in the center of tubercle cassation. If TB bacteria gain entry to the bloodstream from an area of damaged tissue, they can spread throughout the body and set up many foci of infection, all appearing as tiny, white tubercles in the tissues. This severe form of TB disease, most common in young children and those with HIV, is called miliary tuberculosis. Tissue destruction and necrosis are often balanced by healing and fibrosis. Affected tissues replaced by scarring and cavities filled with caseous necrotic material. Clinical features. Pulmonary TB. Black small square. Fever and chills. Black small square. Night sweats. Black small square. Loss of appetite. Black small square. Weight loss. Black small square. Easy fatigability. Black small square. Cough for more than 3 weeks with or without hemoptysis. Black small square. Significant finger clubbing may also occur. Black small square. Chest pain. Black small square. Productive cough or non-productive in smear-negative TB. Black small square. Lymphadenopathy. Extrapulmonary. Tropical medicine tuberculosis. In 15–20% of active cases, the infection spreads outside the lungs, causing other kinds of TB. These are collectively denoted as extrapulmonary tuberculosis. Extrapulmonary TB occurs more commonly in immunosuppressed persons and young children. In those with HIV, this occurs in more than 50% of cases. Notable extrapulmonary infection sites include the pleura in tuberculous pleurisy, the central nervous system in tuberculous meningitis, the lymphatic system TB lymph nodes, the genitourinary system in urogenital tuberculosis, the bones and joints in Pott's disease of the spine. When it spreads to the bones, it is also known as osseous tuberculosis, a form of osteomyelitis. Sometimes, bursting of a tubercular abscess or skin results in tuberculous ulcer. An ulcer originating from nearby infected lymph node is painless. A potentially more serious, widespread form of TB is called disseminated TB, commonly known as miliary tuberculosis. Miliary TB makes up about 10% of extrapulmonary cases. Diagnosis: investigations. Signs of lung disease or constitutional symptoms lasting longer than 2 weeks. Chest X-ray. Multiple sputum cultures for alcohol acid fast bacilli spot sample and early morning sample. Tuberculin skin tests, Mantoux or HEAF test. It is a preferred test for testing for TB in children, and also determining people at risk of developing TB. Hematological tests. Full blood cell count FBC. Erythrocyte sedimentation rate ESR. Increased ESR strongly creates suspicion of the disease. Tissue biopsy. Relationship between HIV and TB. Effects of HIV on TB. Development of active TB once infected with HIV. High risk of becoming reinfected with a second strain of TB. The incidence of TB increases, cases of TB on increase because of TB. Presentation of TB changes once one is infected with HIV. There are clinical changes, e.g. non-productive cough, no hemoptysis, bacteriological changes, e.g. instead of cavitations, there is a miliary pattern. Development of complications of TB quickens. TB treatment also changes once one is HIV positive. Rifampicin is replaced by rifampicin. Effects of TB on HIV. TB increases the replication of HIV, hence increasing the viral load and fastening the onset of AIDS. TB is one of the commonest opportunistic infections in HIV and is the commonest cause of death in 30 minutes, 40% in people living with HIV/AIDS. Tropical medicine tuberculosis. Increased recurrence rate of TB after completion of treatment. Drug resistance leading to multi-drug resistance NDR and extra drug resistance XDR. MDR TB. EDIT TB. Increase in defaulter rates, hence compromising adherence. Increase in side effects, toxicity of agents used. Management of HIV and TB co-infection. Or treat TB first. ARVs are not an emergency. Or start ARVs if CD4 350. After finishing TBRX course or after completing initial intensive phase. After 2 weeks on TBRX. Or consider drug interactions in HIV regimen selection. Or DOTs and careful monitoring. I'll monitor for toxicity and act quickly. Or opportunistic infections prophylaxis as indicated. Complications of TB. Pleural effusion. Pericardial effusion. Empyema. Pneumothorax. Lung fibrosis. Lung collapse. Seeding of infection to other organs causing extrapulmonary TB, e.g. TB meningitis. Treatment of TB. Aims. To cure the patient. Prevention of complications and death from TB. Reduce TB transmission. Case definitions. New case. A person who has never had TB treatment or took TB treatment for 4 weeks or less. Relapse. Patient who was diagnosed with TB, took anti-TB drugs and completed the course. Was declared cured and now becomes smear positive again. Failure. It is a person who continues becoming smear positive at 5 months despite tropical medicine tuberculosis. Drugs used. Black small square. Rifampicin R. Black small square. Isoniazid H or INH. Black small square. Ethambutyl E. Black small square. Pyrazinamide Z. Black small square. Streptomycin S. Treatment regimen. Short course TB treatment regimen. Patient category type of TB. Initial phase. Continuation. Phase 1. New smear positive. 2. New smear negative. 3. Severe extrapulmonary. 2A is 6A. 4. Previously treated smear plus V. Relapse. Failure to respond. Return after interruption. 2C/1A is 5. EHR. 5. Any form of TB in children. 6. Adult non-severe extra pulmonary. 2. HRZ. 4. HR. Non-anti-TB drugs used in TB. Pyridoxine Vit B6 for treatment of peripheral neuropathy, a side effect of isoniazid. Steroids in the treatment of OTB meningitis, OTB pericarditis, OTB of adrenals. DOTS directly observed therapy short course. How it works. Black small square. The country has adopted community-based TB care with DOTS. Black small square. There is a trained worker or treatment supporter who watches the patient as swallow takes. The dose of treatment dolly and records on the TB card. Black small square. DOTS is a standard of care for all cases and suspects of TB. Black small square. DOTS can lead to decrease in relapse, defaulter and acquired drug resistance. Black small square. Use of DOTS with other measures promote adherence. Black small square. The diagnostic center after making TB diagnosis and treatment initiated records in the health unit TB register. Black small square. The sub-county health worker transfers the information to the sub-county health worker register and then goes to the village where the patient comes from and identifies a treatment supporter together with the patient. The treatment supporter is trained on observing patient take treatment, recording on the TB card, keeping the drugs. Tropical medicine tuberculosis. Black small square. Sub-county health worker collects medication from the H/unit and brings it to the treatment supporter. Prevention. Early detection of cases and problem management. Early case findings. Health education about TB spread and prevention. Training of all health worker about early signs of TB. Vaccination of children with BCG. Prophylaxis with isoniazid for people at high risk.